Hello, Alexis.
Hi.
I'm so glad we're doing this.
I can't believe we're like across the world from each other. It's
I
crazy.
know. It's one of the wonderful things about technology. And yeah, so welcome everybody. We're so glad to have you here. Today, we're going to be discussing one of my favorite topics, which is POTS, with the wonderful Dr. Alexis, who has agreed to join me today. I'll just introduce myself quickly if we haven't had a chance to get to know each other. I am a naturopath and clinical nutritionist with over 14 years of clinical experience. I am based in Australia, so my husband's Australian, and we have three boys, and we are based in sunny Queensland in Australia. And I personally have been dealing with a myriad of conditions for a very long time. So, endometriosis symptoms reared their ugly heads around 11 years of age. It took me about 12 years to get a diagnosis. I became pregnant with my first son, which was my big trigger for dysautonomia. So, I developed POTS in pregnancy, and it's kind of spiraled and evolved since then into this very immune hypermobile. I did back then, there was no one was talking to me about how my hypermobility and my immune symptoms were tied into all of this. So it was just here are salt tablets, wear compression. I was then diagnosed with a potentially fatal type of cardiac arrhythmia, so I had to be put on a beta blocker, which did help my POTS. But yeah, it was back then, it was just beta blockers, salt, compression, and no real searching for other drivers. So over the last few years, there's been, I feel like, what do you think, Alexa? Since COVID and long COVID, there's been a lot more attention
For
on
sure.
on all of this. So
A
that's
huge surge.
yeah. So that's when I really discovered the severity of um, how much my symptoms were driven by vascular conditions and my hypermobility. And so I've since discovered I've got, pelvic venous disease. I have intra-abdominal compressions, thoracic outlet syndrome, jugular vein compression, and so on and so forth, which are my big drivers. So yeah, so today we're kind of thinking outside the box. We're going to be discussing a few things that you may or may not have talked about with either your close circle, your support community, or your medical and health providers. So I hope we provide you with some wonderful insight today. And just as a heads up, you're gonna have to excuse me if I am a little bit squirmy. I'm never super comfortable sitting in an office desk situation, and I do have a very hypermobile neck. So my head and my neck is my biggest driver. So if I'm moving and squirming, don't yeah, think it's anything else apart from me. Yeah. So feel free to take it away, Alexis. Can you please just, introduce yourself? Tell us a little bit more about the work that you do and what piqued your interest in POTS and dysautonomia.
Yeah. Thanks so much. And thanks for having me. I'm so excited to have this conversation. I'm a general cardiologist. I started practicing after all of my training and fellowship at Emory University in 2012. And at that time, I really wanted to do cardiology for women. I wanted to be, a women's heart expert. And I saw a lot of female patients and a lot of female patients with palpitations and dizziness and
Mm.
syncope. And some of them came to me saying that they thought they had POTS, and I had really no idea what that was. And so for me, POTS was brand new as of, starting off as an attending, and I had to teach myself sort of along the way. And I learned a lot from my patients, and they taught me a ton of, different things and different strategies for POTS care. And so over time, I started seeing more and more patients with POTS. I think um, I like to hear stories, and I really enjoy sort of listening to patients, but also I feel very strongly that when patients say that they have a symptom, it's real. And I
Yeah.
think that that resonated a lot with this population of patients, and they weren't really hearing that from anyone else. And so I started developing more and more patients with POTS, and then started taking a deeper dive into kind of what's actually going on with these patients. So, I started off just like you were treated. I started off treating POTS in the same way with
Yeah.
salt tablets and fluids and, beta blockers, Midodrine, Floridef, this kind of thing.
Yeah.
And then I started realizing that patients had food intolerances and medication intolerances. And every single patient that came in seemed to have an allergy list that was 10 meds long. And this
Yes.
seemed weird to me, And then I started looking at lower extremity veins and finding venous insufficiency in almost all of the patients and wondering why that was. And then I started learning about Ehlers-Danlos and hypermobility, and
Yeah.
then I started learning about pelvic venous disease. So it's sort of like evolved over time into a greater awareness of sort of a more global picture of POTS. And that to me, is really interesting because as a cardiologist, I went into this thinking I was going to take care of women with heart disease and heart attacks and atrial fibrillation and things like that. And I still love doing that. But POTS is a world that's, not well understood and challenging. And
Yes.
that's fascinating to me. I like, learning every day and figuring things out. So I think that's why I'm drawn.
And as someone who has seen many cardiologists, it's so rare to find someone like yourself in this field because, correct me if I'm wrong, but from like a classic cardiologist's perspective on POTS, you're not really delving into all the things that we consider. Is that correct?
Right. So, yeah, I think most cardiologists are very happy to rule out all of the bad things. Like,
Yeah.
let's make sure you don't have a horrible arrhythmia that's causing you to pass out. And let's make sure your heart's structurally normal and you don't have plaque or, or coronary artery disease. And once all those things get ruled out, I think we decide that there's nothing wrong with your heart, which, to be honest, in POTS, usually there is nothing wrong with your heart. It's a lot of other symptoms that are happening, right?
Mhm.
But all of those symptoms are related to cardiac symptoms. And so
Yeah.
that's how the cardiologists get involved, right?
Yeah.
And so once a cardiologist rules out the heart, they kind of throw their hands up and say, there's not much I can do for you. You're going to have to find someone who specializes in this area. And that happens a lot. And I don't blame other cardiologists. I didn't learn about this in my fellowship, in residency, in medical school. No
Yeah.
one is taught, how to manage patients with POTS. I mean, now people are learning a little bit more. I certainly was doing a lot of teaching at Emory, but this is not on the cardiology boards in the way that, treating hypertension and atrial fibrillation is, right? So we just don't know as a group of doctors. And so it takes someone who wants to, figure it out a little bit.
Do you think that patients are becoming more complex and kind of not fitting the box as much? Like, especially when we're seeing long COVID emerge, and it's presenting with dysautonomia symptoms, MCAS, and then you realize, oh, they have this part of this musculoskeletal aspect where they are hypermobile also, and
Mm-hmm.
then they have vascular compressions and this and that and whatnot. Like, do you think
Right.
cases are becoming more and more complex due to things?
Yes,
No.
I do. But I think it's more a matter of sort of environmental factors, genetic factors. I think, when I think about my patients who are in their 20s and or teens, when I talk to their family members or their parents, oftentimes, when I'm asking the patients all about their symptoms, the mom is sitting there like, yeah, I have that and that. Like, yeah,
Mm,
I have all of those things.
yeah,
Um, but the mom is much more functional and sort of not as affected. And
yeah.
the child is like severely debilitated and really
Debilitated.
struggling and really having a hard time. And I think that that's, partly our environment, the way the environment that this younger generation is growing up in, like what kind of external
Yeah.
factors are causing more reactivity, more mast cell dysfunction, more hypermobility. Like, I think it's snowballing a little bit from generation to generation. And so it does seem like everything's getting more complicated, but maybe it's just like what we're doing to ourselves. I don't know.
Yeah, no, I think you're totally spot on with all the things, and then new viruses and new illnesses and
Yeah.
everything combined, of course. And if you've got that genetic predisposition, I know that, we say that there is no genetic evidence for heads or hypermobile EDS, but yeah, I don't know. I've seen
I
some
mean,
yeah, come out, and it's like, oh, well, maybe we are
there's
looking closer to finding something.
I think we're getting closer and closer. I think that there are research groups now that are dedicating their time to EDS. It's amazing. There's a group at
Mhm.
in Charleston. There's a group in Denver. You know, people are looking at this and trying to figure out what's going on and what the source is. Um, I can't imagine that there isn't some genetic component, even if it's multifactorial or multiple genes, or but there is a population of people on
Yeah.
this earth who are more susceptible to injury from vaccines or from specific vaccines. I don't want to go there, but
Yeah.
from viruses, from Lyme disease, from,
Mold.
chemical pollutants, from mold. Yeah. I mean, mold is a good example, right? Like you can live in a house of mold and one person is totally fine and is not affected, and the other is deathly ill, right?
Yes.
There's a predisposition there. Where you have the same exposure. Mold is, you're both experiencing the mold. Why is one person super sick and one person is like not affected at all? There's something underlying, right?
Yeah.
And
And I
so
guess,
that's this population of patients.
yeah. And that's when we look at like, maybe I'm biased because I'm a naturopath and love my functional medicine stuff, but that's when you look at how are you detoxifying and clearing mycotoxins? Are these genes compromised? And so on and so forth.
Yeah. Right. For instance, yeah, exactly. So, I mean, I don't know as much about the naturopath, like functional medicine component of all of this, but I think it's fascinating and very valid. Um, but you're right. Like, is my liver working differently from your liver? Is there, some pathway that is working in one person and not working in another? Sure. Like, are
Yeah.
these things that we don't know anything about? Absolutely. Systemic problems, in humans that we don't know anything about? Yeah.
Yeah,
And
definitely.
I think it's hard for a lot of doctors to say, like, yes, we don't know what that is. Let's try to figure it out. I
Yeah.
don't know. I think
And the
we
hard
try
thing
we
is
try
we
to
don't
believe that we
have
know
gold.
everything.
Yeah, and the difficult thing is we don't have that gold standard evidence for it all yet, but we're
No.
seeing it on repeat in clinic, and we're, seeing
Yeah.
it on repeat in people, in our
Yeah.
community, support groups, and so on. So
And
yeah,
that does make it harder to practice, right? So, you see this all the time. I see this all the time. I know it helps. I know what gets people sort of to the next level of functionality. And it's from seeing a high volume of patients that I have this, knowledge and this kind of expertise in this area. But I didn't learn it anywhere. I couldn't read about it in papers. Like it just doesn't, it's
we're
not
not there
quite
yet.
prime time.
Yeah,
Yeah. And
yeah,
so it's hard to sort of validate what you're doing sometimes,
yeah.
but you know,
And
hopefully
I
it'll
just
come.
wanted to, before we go any further, I just wanted to let everyone know. Yes, so if you have any questions, we will be doing a Q&A in the last 15 minutes, so in about half an hour. Please use the chat box to type your question in and we'll go through them at the end. Um, Amazing. All right. So, what are some of the non-negotiables um, for a newbie Potsy for you in terms of care um, from a cardiologist perspective, self-care, whether it be
Hmm.
pharmacological or non-lifestyle, whatever. What are some of the non-negotiables or things that you always advise your patients?
Right. Right. So I saw someone today, right? And the first step is like the basics. So you have to be drinking enough water, you have to be eating enough salt. I recommend 90 to 120 ounces a day of water. I recommend 6 grams of sodium. A lot of people recommend more, like 10 grams, which is fine. Kind
It's
of
so
depends on where
hard
your
to
blood
get
pressure
in.
starts.
Yeah.
And I think it's all about the ratio of salt to water. It's not as much about overloading the salt. You just want to have enough salt in your system so that the fluid gets into your bloodstream, right? So, there's a range. Compression is essential. So compression socks or compression garments, abdominal binders, abdominal compression is really useful. I, and then I always instruct patients to try a gluten-free diet because I think it's low-hanging fruit. And I think if you haven't tried it before, it's worth it. I have patients who come back and tell me, you know what, like all my symptoms are gone just because I stopped eating gluten. And I'm like, great.
Wow.
We don't have to do anything else, right?
Oh my
I
gosh,
mean,
that's
that's rare.
amazing. That's amazing for
It's
them.
rare.
Yeah.
Yes, and amazing, but it lends to the whole sort of autoimmune kind of
Yes.
stuff. Like, why gluten? Why are they reacting to it? Right.
Yeah.
But it is low hanging fruit, right? Like, why not? And if it doesn't help, then go back on gluten. I don't care. Right.
Yeah.
So there are those are kind of like the first things I say. I also recommend a trial of antihistamines because I think that's also kind of, not toxic and could be helpful to see if it improves their symptoms at all. So those are sort of like the first things. Once a patient's on all that, doing that, and they come back and they say, maybe I got a little bit better, but I still feel horrible. Then I start looking at medications. I start doing other testing. So, kind of my go-to medications are beta blockers, Midodrine, Florinef. I use a lot of SSRIs in my clinic because they've been shown to help with POTS and they seem to help in some percentage of patients. And this is for venous return. This is not for anxiety or depression. This is to help with fluid return back to the heart. And then I look for things like venous disease, mast cell activation syndrome, other compressions, median arcuate ligament syndrome. So I have a detailed sort of
Yeah.
question list that I go through to see if any of these hit and any of these seemed like something that I should be looking for.
Yeah, nice. I love that you do incorporate dietary recommendations.
I have a lot of diet things. I don't know if they're right or not, but
Oh no, I think it's amazing. I think it's rare. I've never had a cardiologist tell me anything regarding food except for salt, really. What are
right.
some tips that you tell your patients to get to really reach that 6 to 10 grams of sodium a day? How do they
Like
get?
how? Yeah.
Yes, because
So
it's hard, especially if you've
it
got
is hard.
like the mouths or, a lot of people with POTS have chronic nausea. I remember salt
Yeah.
tablets feeling like they'd explode in my stomach
I
back in the day.
know.
This was like over a decade ago, and we didn't have these
Yeah.
nice electrolyte options. We had
Yeah.
literally salt bombs.
Salt. Right. So I was speaking to a patient today actually about this, and she was saying how she had a real intolerance for any kind of artificial sweetener. She had like a really hard time with all of the electrolyte replacement beverages. And the one she found that she tolerated was like this Walmart brand electrolyte replacement. And it had 500 milligrams of sodium, and she was doing it once a day. And I was like, that's not enough. Like, you're a college student in Georgia and you're walking around campus all day and it's 90 degrees out and it's humid and you need more. And so we talked about like how she could get that in. Heavily salting your food is one way. Obviously, I told her that she could try Normalite tablets because those capsules are smaller. They don't have as much sodium in them. But I specifically told her I could give her a prescription for salt tablets, but I thought it was going to make her nauseous. She had a history of cyclical vomiting. I was like, I just don't think it's going to be right for you to put that in your system that way. But you might be able to tolerate this lower dose capsule.
Like a
And so she was
Vitacium
going to
or
try that.
something like that.
Yeah. Yeah.
Yeah.
Instead of like chewing something, or just like those
Yeah.
Normalite makes one too, but it's like a capsule of
Nice.
sodium.
What
And
do you,
so,
oh, sorry.
yeah.
What do you think about IV fluids, IV saline? Is it kind of like a
It's
double-edged
not my
sword?
favorite.
Yeah.
I mean, everyone feels better after IV fluids, unless you have true like multi-system atrophy dysautonomia. Then those patients surprisingly tell me, I don't feel any better after that 2 liters of fluid, doc. And I'm like, okay, you don't have POTS. You need to go really see the neurologist that specializes in autonomic disorders, because that's not me. Um, Most people feel great after some fluids. I I really try to avoid them on a regular basis. I love using IV fluids in the setting of a flare. If
Mm,
someone has a GI illness, or
mm,
can't keep anything down,
mm,
or has a viral infection, then yes to IV fluids. But my patients who do IV fluids regularly, their body gets very used to IV fluids, and it's hard for them to be without. And
yeah.
then their veins start blowing because they've gotten so many different IVs. Their access goes away, so they no longer have any venous access, because in patients with hypermobility spectrum disorders, your veins are just fragile and not going to
Yes.
work as well. And so then we go down the path of the port or the central line, and then my patients develop, bacteremia, endocarditis. I have patients who've had this problem, and it's terrifying. I mean, you can die from that, right?
Yeah.
So I really try to avoid IV fluids at all costs. The one time I use them up front, sort of in the beginning, is for people who have horrible GI symptoms, like very bad gastroparesis, very bad cyclical vomiting, like,
Yeah.
very bad. It's just they can't keep anything down, and they're chronically dehydrated because they literally aren't ingesting food or
Yeah.
water.
Yeah.
If you're not adequately hydrated, that system is never going to come back to work again, right? And
Yeah.
so we have to get those patients well hydrated in order to get the GI tract to absorb liquids, absorb food, and get them on the right track, right?
For
So I
sure.
do use it then, and I very much caveat that this is like a bridge to hopefully coming off of it, and we're not going to use it for a long time. And let's try to heal the gut and get the GI tract working. So
Yeah.
that's one
No.
exception. You can't
Yes.
fix POTS if someone's not eating or drinking.
Yes. The
It goes
tricky
much
thing,
further than.
yeah, and the tricky thing is that so many people with POTS do have those,
Yeah.
do have complex dysautonomia with GI
Mm-hmm.
involvement and so on. Um,
Mm-hmm.
I have a lot of questions. I'm just thinking maybe we can start looking at them. Um,
Sure.
what do you think? Oh, someone recommended
Yeah.
Pure and Boy for electrolytes.
Uh-huh. Yeah, I
Um,
love buoy. That's
Sorry, I
I
didn't pronounce
find
it
that
correctly.
it's it's these drops that you put in your water, and I don't know, you have to put a whole bunch of those drops in to get enough sodium. It seems to
Yeah.
help. Patients do like it, and patients do find that it works, and it's not artificially sweetened, and it's not overly like flavorful, but I do think you need a lot of them.
Yes,
So
that's what I find with the electrolyte drops. They're liquid drops, right?
yeah,
They're usually like a
yeah.
multi-mineral blend.
Hmm. Hmm.
Yeah. Personally, yeah, that was the issue with me. It just wasn't helping me hit the sodium levels. But maybe because of the
Right.
balance of minerals, it was still helping in other ways. Um,
I think probably. I think
yeah.
that there's definitely some utility to it for sure.
Yes. Um, Alexis, are you able to see the chat, the rolling chat?
Um, yeah.
Do you want
So
to pick a couple?
um,
Just because
should we
there's,
start from the top?
yeah, go for it. Celiac
Okay.
heads,
Uh,
fibromas. Are
okay,
you?
so this one person's asking specifically about POTS, MCAS, fibromuscular dysplasia, and sudden coronary artery dissection, which actually go along quite often. So in my population of patients with POTS, I often diagnose fibromuscular dysplasia. It's very common for those two to overlap.
Mhm.
And fibromuscular dysplasia is a disease of the inner lining of the artery, so like the interior segment, and it causes beading in the arteries, in these kind of medium-sized arteries, and that can cause narrowing and stenosis, which then can cause problems with the kidneys, problems with the blood pressure, etc.,
How is that
or
ruled out?
carotid disease.
How is that diagnosed?
I usually start with ultrasound, but you can use CT angiogram also
Mhm.
to
Okay.
look for that. And I often look for it in patients who have high blood pressure who come to see me, because young women with high blood pressure, shouldn't have high blood pressure. And if there's no family history and it seems like it's not in the right place, then it could be something. It
So
could
red
be
flag.
fibromuscular dysplasia, could be renal artery stenosis. It could also be mast cell activation syndrome and labile blood pressure from that, right?
Yeah.
And so the question is, she's taking fludrocortisone, but there are other options overall for POT symptoms. So fludrocortisone is a medication that expands blood volume and helps raise blood pressure, and in turn, it'll lower your heart rate because you have just more blood volume. It's our way of kind of, it's a second way of expanding the blood volume after trying to drink a lot of water and eat a lot of salt, right? The problem with fludrocortisone is it's not always well tolerated. Patients gain a lot of weight. They get headaches. Like, people don't really like it that
Yeah.
much. And so it's not, I don't really use it first line anymore, although I used to love it because it's once a day, which is great. But I don't really use it first line because I got so many complaints from patients. And so I usually start when it's a blood pressure issue. If there's not enough blood pressure, then I usually start with midodrine, which is unfortunately 3 times a day, but it is short acting. So
Mhm.
you can kind of, you can take it and use it sort of as needed if you want. And so I like that aspect of it, but it raises your blood pressure, doesn't have as many side effects. Some people get an itchy scalp on midodrine, but it seems to do the trick. And people find that they have less brain fog and fatigue when they're on it because it just helps get blood flow to the brain.
Yeah, the
So
midodrine
that would
tingles,
be
I used to call them.
the midodrine what?
The midodrine tingles, your whole head
Oh yeah.
tingles.
Yeah.
Yeah.
Right. I mean, this is not uncommon.
Yeah.
People get this, right? And so I would, so if someone's not tolerating fludrocortisone, we might try midodrine. I also, often add on beta blockers or use them in combination. Let's say someone comes in with a low blood pressure, but really has a really high heart rate, and I really want to try a beta blocker. I'll put them on midodrine or Florinef just to get their blood pressure up enough to add the beta blocker. So it's like a combo
Mm.
therapy in that regard.
Would you do a Vabradine
So
instead of the beta blocker in someone like that?
I do. I use a Vabradine all the time, but I usually don't start with a Vabradine first line just because I love the other side effects of beta blockers in this
Yeah.
population of patients. So oftentimes they help with a little anxiety, a little bit of, they just like calm your nervous system. They calm the sympathetic, drive.
Hmm.
If Vabradine doesn't do that, it literally just slows the heart rate. That's it. And
Yeah.
so and I used to wait on a Vabradine because it was so expensive and you couldn't get it. Now it's easy to get and it's cheap.
Hmm.
But so my habit is to start with other medicines. Maybe that'll change, but I do think it's a great option. It's just not usually my first one.
Yeah. No, that's good. Um, and oh, this is an interesting.
So
Oh,
yeah, go
was
ahead.
that it for that question?
Yeah.
I
Uh-huh.
mean, there's an interesting one about mold. From the toxins path, if you know you've lived in 4 mold-infested homes, should that be considered? Absolutely. Absolutely.
Hmm.
Especially, as we discussed, you may be more predisposed to this mycotoxin buildup. Following on that, I would
Yeah.
any recommendation ways you can do without prescription or ways to manage that. Unfortunately, mold is still a factor.
I'm
Okay.
going to let you take that one, Kimberly, because
Any sort of air purifiers, you can do all the things in your environment, like open your windows. If you can get air purifiers, that's great. But really, there's nothing that beats getting out of that environment to allow your body to have a break from it. Especially if you've got the POTS, MCAS, that would be an extremely significant trigger for MCAS. IBD, your gut. So it's kind of hard to say without understanding your whole case. But from a naturopathic viewpoint, we would want to ensure that you are clearing toxins through your gut, your liver, your kidneys. If you've got this immune activation, this heightened inflammation constantly, that's going to compromise everything. Um, and Yeah, you would need a personalized herbal, nutritional, dietary protocol, lifestyle, but things you can do. lymphatic clearance, manual trying lymphatic, just gentle lymphatic massage, even just to get your lymph moving, hydrating, obviously eating a very low processed diet. If you've got IBD, I don't know if it's Crohn's or ulcerative colitis, but getting good amounts of essential fatty acids, omegas, good quality fiber, a high count of plant foods. So if you can tolerate up to 30 different plant foods a week, that's the goal for gut microbiome, good gut microbiome balance. But it is hard to kind of go, this is what you need, if you can't get out of a toxic environment, really. If the biggest trigger for you is the mold, all the other things that we're doing is kind of just barely masking. We're kind of just trying to band-aid. It's like whack-a-mole. We're trying to do all this stuff, but the mold is
Yeah.
the biggest trigger. So in that case, anything you can do to help clean your environment up, would be the biggest help, I would say. Like you would still need to keep your drainage pathways flowing. You want your lymphatics, and if you've got heads and pots, you may have, compressions that are compromising your lymphatic flow. You want that to be flowing freely. So if you can see a good lymphatic therapist, that would be great. And then doing your own lymphatic stuff at home. There are
Do
certain
you ever recommend, the Perrin technique? Do you
Yes,
know that?
if you can find someone who can do that, yeah, absolutely.
Yeah.
But they're
But
rare.
they also have on their website like a self instruction, like a guided self lymphatic
Yeah.
drainage.
So
I don't know if it's as good, but
yeah, I mean, do whatever you
whatever
can
you can.
do. Um,
Yeah.
the gosh, Stop Chasing Pain. He's got some amazing resources there for um all sorts of different lymphatic techniques. But yeah,
Hmm.
there are lots of different schools of thoughts when it comes to lymphatic therapy and manual lymphatic drainage. I haven't come across anyone who hasn't benefited from it, anyone with like POTS, MCAS, and heads, because it just
Yeah.
gets things moving. And we need to remember that unlike our blood flow, our lymph isn't being pumped. It doesn't move like our blood does. So
Hmm.
manually moving it can be very helpful in clearing and draining. But
Yeah.
yeah.
I agree for
Um,
sure.
yes, and mold
Let's
is
see.
very, very tricky. Unfortunately, so many people are becoming ill from mold, and yeah, it's a hard one to
Yeah.
manage. Okay, this one is a
Yeah.
this is a long one. Vascular compression. Alexis, you want to take it?
Yeah. So, are there any movements to create standards in this space? 17 plus specialists. I know, I'm sorry. Um, I think I think there is movement. What we're talking about here is in the past, pelvic venous congestion was considered varices of the pelvis. So often related to like multiple pregnancies, you develop these varicose veins in the pelvis where blood pools. And the
Mhm,
treatment for that was sclerotherapy, where
mhm,
the interventional radiologist would inject foam and put coils in these large varicose veins so that they would shrivel up and go away.
mhm.
That way, there was no blood pooling in those veins anymore. So you wouldn't have that. Essentially, what they were treating was pelvic pain, right?
Yes.
Um, but over the years, we started learning that these accumulation of veins or the varicose veins were coming actually from other compressions. So one form of compression is a gravid uterus. When you're pregnant and you have a huge uterus, it's pushing down on all of the IVC and the iliac veins, and that's causing dilation of veins around it. If you have normal veins, and you give birth and the uterus shrinks up, then the regular veins are going to have their normal pathways, and those varicose veins are going to kind of, those collaterals that had formed are going to go away because your normal pathways are opening up again. If
Hmm.
you have veins that are abnormal, for instance, if you have a collagen abnormality, if you have hypermobility, then the veins that were compressed during during that time when you were pregnant may open up, but may not open up completely. And the collateral veins that formed don't shrivel up in the same way. They still pool blood. You still get this like filling there. And so the treatment for that initially was sclerotherapy and coiling. But what we found was that not everyone benefited from the sclerotherapy and the coiling. People still had pain in the pelvis. And people started looking at other things like iliac vein compression and renal
Yeah.
vein compression. So renal vein compression is what causes the gonadal vein to dilate, and that's what causes a varicocele in men or these ovarian vein, dilated ovarian veins. The
Mhm.
gonadal vein gets dilated and varicosed and kind of robust, right? With May Thurner or iliac vein compression, you get other collateralization. You get cross pelvic vein collateralization. You get veins that go up and down the spine.
Mhm.
And so these are not veins that normally would get sclerotherapy treated, but if you open up the iliac vein, then those veins start to disappear because the flow of blood is going in the proper direction again.
Mhm.
So people are discovering these different aspects of venous disease. First and foremost, I will say that the veins are like a lost organ system. It's similar to the lymphatics, I will say,
Yeah.
almost maybe worse because we've never really known much about the lymphatics anyway. But the veins, like, no one cares. No one wants to learn about them. Everyone thinks it's just, like they're there to bring blood flow back to the heart. Woohoo, who cares, right?
Yeah.
But the reality is they hold a lot of blood volume. They can get very large and distended,
Yes.
and there's disease processes that go along with that distension, like aggravating mast cells or other
Yep.
tissues or pain, chronic pain, flaring nerves, everything, right? So we're just moving into this space now where we're finding different treatments for these problems. The issue is that some people are very, very far along in their
Yeah.
research and their thought process in this space, and others haven't gotten there yet or didn't learn about it in fellowship, and so they're not aware and they don't understand. So if you have pelvic pain and you think you have pelvic venous disease and you go to an expert in iliac vein, ooh, sorry, my dogs, an
It's
expert
okay.
in iliac vein compression, hey, shh, stop. um, then they're going to say get your iliac vein stented. That's going to help. Thanks, well. Um, if you go to someone who is not an expert and who doesn't do a lot of venous disease and who, prefers to take care of the arteries or whatever, they're going to say that doesn't do anything. Your symptoms aren't related to that compression. Like, I don't believe that any of this is, related. Like, you don't have to get anything fixed. You're fine. Right.
Yeah.
So that's very confusing for patients because who do they believe? Like,
Yeah.
it's hard to know. Right. And so when you start going down the slippery slope of seeing more and more doctors and everyone has a different opinion, it's because we don't have real data to support which path to take first. Do you do the sclerotherapy first? Do you stent the iliac vein?
Yeah.
The experts that I work with believe that stenting the iliac vein first is first line because a lot of patients have
Yeah.
resolution of other symptoms when that happens. Sometimes you also need to do sclerotherapy of the veins of the pelvis. Then there's oftentimes a concomitant renal vein compression, and sometimes that needs to be treated as well. But oftentimes it doesn't. So sort of going for the low hanging fruit can be all you need. But we don't know. The answer is we don't know, and we're working on it. I was just on a call with several specialists who do these procedures, and we're trying to come up with a randomized controlled trial for POTS, long COVID, pelvic pain,
Mhm.
to prove that this is an adequate, this is one treatment that could be an option. Um, but it's going to take years,
Yeah.
years and years and years to get randomized controlled trial data that's adequate for, everyone else to sort of buy in. So unfortunately, there's not a great answer.
It is. Yeah. It's so many of these, I mean, just this subset of patients with these conditions, we are the rare ones, So there's hardly anything on how to how to manage and how to resolve our issues. We all
I would
respond.
even argue, yeah, I would argue not necessarily rare, just misunderstood, underdiagnosed, like not well
True.
classified or characterized. That's the problem more than anything else, right? And so it's going to take time to get that information out there, and it's really hard. I at Emory for 13 years, I did research. And so I had a population of 600 patients in a registry, and we were looking at pelvic venous disease and lower extremity venous disease and all other kinds of things. And it was really hard for me to do alongside my very, very, very busy clinical practice.
Yeah.
And I couldn't find people who wanted to jump in and help me do this research, but I was interested in it because I see these patients all the time. But it's not, it's just not on people's radar that this is something that needs to be studied. I think it's becoming more and more. Like I think we're getting there a little bit, like inch by inch. More people are understanding that this is an area of research that needs to happen, but it's gonna
I
take some
think with
time.
long COVID, it definitely has become a lot
It's
more
helped.
known. Yeah, unfortunately, but
Yeah,
fortunately.
right. There's definitely been a peak in interest, NIH dollars, all the things for, since we've had the pandemic and all these patients with long COVID, which, I mean, there are nuances to long COVID. It's not exactly the same as other
Yeah,
post-viral chronic illness, but
definitely.
it is the same. I mean, we've been seeing it for years and years and years. It's just now it's long COVID.
Yeah,
Um, Long COVID has some nuances, but it's kind
yeah.
of the same thing, in my opinion.
All right, this is an interesting one. POTS, IST, fibromyalgia, hypermobility, insane itchiness, redness, numbness after going for a walk. Could this just be blood pooling
Mm-hmm.
or further? Sounds like classic histamine to me. Classic.
I would say classic venous disease. So, but I think they go
Yeah,
together. I
yeah,
think when you pool blood in your lower extremities, that activates mast cells to release histamine, and that's
yes.
how you get that
I
itching.
have the exact same thing. Um, yeah, 5 milligrams of Aberdeen, POTS, IST. I can't use compression because they also trigger the itchiness and it drives me mad. Oh, that's
Yeah,
tricky.
which is
That's,
very mast cell
yeah,
mediated, I think.
yeah,
Yeah.
yeah. Struggle to drink 1 liter of water per day as I have bladder issues. Severe anxiety of toilets led me to decreasing my water intake. Vyvanse, fluoxetine,
Hmm.
pantoprazole, LDN, baclofen, Endep. 24, oh, very prim baby. 24 weeks
Yeah.
atonic colon. Yeah.
So
Um,
the atonic colon is interesting. That, like, when I hear that, I think tethered cord immediately, which is another thing that we see in this population of patients.
yeah.
Um, so it's just always something to think about because that's something that's easily fixed and that's not uncommon. So when you have bladder and bowel issues,
Hmm.
it's like until proven otherwise, tethered cord. The problem is finding someone who's going to diagnose you with tethered cord and treat it and all the things. Just like the problem is finding someone who's going to diagnose and treat your mast cell or diagnose and treat your pelvic venous disease. It's always the same problem, right? But
Yes.
this is that's like, that would be the first thing I'd, like, light bulbs go off when I see something like that. And then um the I think, like we said, the blood pooling, yes, mast cell activation syndrome. Hopefully, I do have patients who try lots of different compression and finally find one that works.
Yeah.
So, that's a possibility. The other thing I recommend is pneumatic compression. So you can get these boots that blow up on your legs intermittently, and kind of bring blood flow back to your venous system. And when you can use those for like 30 to 60 minutes a night, and over time it really helps kind of with it decreases that potential space for fluid to go when you're standing, so there's less blood pooling. So if you can't tolerate compression during the day, I recommend those, and sometimes they're more tolerated in someone who's having itching and discomfort from the compression socks.
What about taking an antihistamine before going for a walk?
Absolutely. The
Yeah.
other thing that sometimes works is DAO, pre-exercise.
Interesting. I'm finding that DAO only really works well with gut related histamine symptoms. And Like your H1
Yeah.
blockers are better for non-gut, non-food related. But yeah, you
I
try.
mean, I think that would definitely be my thought too. DAO, usually I use it for histamine. If you're having a high histamine meal, you can kind of digest some of that histamine with the DAO prior to it all getting absorbed into your GI tract. But anecdotally, I have patients that are like, IO before exercise and I wasn't itching. So
Good.
I don't know. Yeah. I mean, it seems like also another one of those things that's pretty low risk. And,
Totally.
if it helps, then
Yeah,
great. Right. So, but I
absolutely.
agree with you. You'd think it should be localized to the GI tract, but maybe it isn't.
Yeah. Yeah. Well, we have lots of questions. We have to kind of zoom through these. SSRIs and venous
Okay.
return.
Which for venous return, I usually start with Prozac just because it doesn't cause weight gain and no one likes weight gain. But Zoloft and Lexapro also work well for venous return.
Interesting. Diet.
Dietary recommendations.
I'm happy.
Yeah, so I always recommend gluten free. I'm going to tell you what I recommend, and you tell me if
Oh,
I'm right or
yes.
not.
Go,
Okay.
go, go.
Um, then I recommend dairy free. Then I recommend corn free. So I tell patients to cycle through. It's like if the gluten free doesn't work, then you can go back on gluten, but try dairy free. And if the dairy free doesn't work, then you could try corn free, etc. I do tell people to avoid processed foods. Try to stick to a whole food diet. An anti-inflammatory or autoimmune diet is great also. But if it's hard for you to kind of restrict, and many of my patients have
Yes.
eating disorders or disordered eating behavior, then it becomes tricky because you don't want to be telling people, only eat these three things, right?
Yes.
But that's kind of where I start. How about you?
I do it from a very individual perspective, but the things that never really go wrong is a low histamine diet, first and foremost. It just kind of helps to, whilst you're doing all the immune work and trying to get things kind of settled, it just brings down that systemic inflammation a little bit more. And there's usually, food aversions, food fears. Um, so going low histamine is usually very effective. Um,
But don't
if
you find it very hard for patients to stick to a low histamine diet? I find that
Yes, so
it's
I
super
have,
selective.
yeah, so I normally go, yes, let's try 4 weeks on it. And I give them meal prep guides, shopping lists,
Hmm.
recipes, and really I go through your diet. I know what you're eating, and I go, okay, so we'd swap this with that. I have the time to go through their food, and so I really
Yeah.
personalize it, which is great. Because yeah, if you didn't have that, it would be hard, I think.
Yeah. Well, you just feel like you can't eat anything,
That's
right?
right. And
I do tell people to not reheat their protein the next day. That's
I
like a
say
huge
if you,
histamine bomb.
I say freeze it, if you
Yeah,
can. So freeze
right.
it and then reheat it.
Yeah.
But usually when people feel better, I'd rather like I don't mind them doing that if they're having a typically like lowish histamine day anyway. It's
Hmm.
all in
Yeah,
balance. Like if you're super stressed
right.
and you're going to go out for dinner and then maybe it's not the best thing to eat leftovers that have been in the fridge for lunch. But if you're, feeling relatively okay, then yeah, heat it up. See how you feel. You usually feel you feel a reaction pretty quickly. Oh, at least I do. If you're classic,
Yeah.
like you may get like an itchy throat, itchy ears, or like a bit throaty, or whatever it is, skin rashy, hives, tummy ache, it happens pretty quickly. So use that as your
Yeah.
guide. So it's always your body's going to communicate to you differently on different days based on, what your nervous system is doing today, how well you slept last night, your stress levels. So yeah, typically I say if you batch cook, which is usually the easier option for, you know, diets,
Yeah.
restrictive diets, just freeze it in portions and then reheat it.
Mm.
But yeah,
Hmm.
the other thing with that we see a lot is autoimmune, obviously. A lectin-free diet can be great. So that's
Oh. Hmm.
based on the principles that lectins are um, protective in plants from other plants and from animals to protect the plant, and they can drive an inflammatory response in us. So
Hmm.
that has been the only diet because after I give birth, I get this crazy thyroid storm and my thyroid antibodies go crazy, and I have to go on this very strict lectin-free diet for 6 months, and it
So
brings down.
what's a lectin-free diet? Give us
So
an
it
example of
includes
high lectin
it's a low grain. It's
foods.
kind of like an autoimmune. Are you familiar with the autoimmune paleo kind of protocol? It's
Yeah.
very similar.
Yeah.
No nightshades.
Okay.
Um, no grains except for lectin-free grains, which are millet and sorghum. But basically
Hmm.
meat, veg, lectin-free grains. Um, you can have goat's cheese, no cow's dairy. It's actually a very delicious way of eating. It's kind of like Mediterranean style. Dr. Stephen Gundry, are you familiar with him? He was a cardiothoracic surgeon.
Yeah.
So he came up with it.
Yeah, he's big.
Yes.
Right.
So I have trialed it numerous times and it works, but it's hard. So for the
Hmm.
antibodies,
Hmm.
it's effective whilst you're also working on gut health and stabilizing mast cells and cleaning up your environment and reducing
All
your
the things.
exposure. Yeah. So that's kind of the way that I
Hmm.
approach this when we talk diet. And of course, getting salt in through low histamine foods. That can be tricky because a lot of high histamine foods are high salt.
Right.
Yeah. So,
Right. Right.
um,
Okay, should we try to
oh yeah,
tackle a
yeah,
couple
for
more of
sure.
these?
There's a lot here. We won't be able
Um,
to answer them all, but
can dysautonomia, vertigo, small fiber neuropathy, tinnitus, Raynaud's flare at the same time? Can be connected as MCAS or something else? So I see these flare together all the time. Like these are common symptoms that flare in my patients with POTS and hypermobility. Uh,
definitely.
one thing to note is, some of these symptoms could be related to hormone shifts like perimenopause and menopause. So there's an overlap here that happens. And that's like a whole nother hour-long conversation about how our hormones regulate mast cells and
Yes.
aggravate, put you in flares and trigger all kinds of symptoms. And I think that it's fluctuations in hormones. Personally, it's not necessarily high estrogen or high progesterone or low of one or the other or testosterone or whatever, but it's like when they're all cycling around and shifting, that's when we get really messed up.
Yeah.
That could be an issue
Especially
also.
because perimenopause is such a fluctuant time. I mean,
Yeah,
you're
I think,
fluctuating.
yeah, I can't say. I had this patient who told me that her long COVID went away when she had a hysterectomy and got put on hormone replacement therapy. And I was like,
Well,
well, I mean, and she was like in her late 40s and
yeah.
clearly was in perimenopause, and no one really figured that out. The hard thing about perimenopause is that you're fluctuating all over. So just putting you on hormones is not going to make that necessarily much better. But for her, it was removing her ovaries and then putting her on a stable
Stable.
dose of estrogen
That's
or
it.
progesterone. And all of a sudden she was like, I feel great.
Yes.
I'm totally
And
cured.
yeah, and
So
as
something
someone
to consider when you're thinking about.
exactly. And as I specialize in endometriosis and women's health anyway, it's
Yeah.
so obvious that there are correlations with different parts of your cycle, and these
Yes.
symptoms. So definitely,
100%.
definitely.
That's
And
a whole nother talk too.
yes. Um,
Hmm.
what's the next one?
Hmm.
What's have to be? Oh,
EBV
interesting.
absolutely is a trigger, absolutely can be an underlying cause, can be reactivated in the setting of COVID, can make everything worse. It's definitely a player in all of this.
Yeah.
Um,
Highly sensitive nervous system. Like, is that causative in why some people who
yeah,
have hypermobility don't necessarily have all these symptoms? Well, I think it's a combination of many things. Um, it could be, but how do we define a highly sensitive nervous system, right? From a purely
yeah,
scientific and medical viewpoint. But we know that layers of trauma, for example, will dysregulate your nervous system. You compound that with, multiple viral illnesses as a child. And, as a child, I had extremely painful periods from the get-go and medical trauma and interventions and, extended periods of time on hormone therapy and gut meds from such a young age. So that could then trigger you to have a very sensitive nervous system and be totally dysregulated, which would then prime you. And then, you have the venous predisposition, and then pregnancy or a vaccine or a big illness or something, then, tr tips you over
yeah.
the edge. So,
I think of it also like all of these patients have all of this, right? So
Mm.
at least MCAS POTS and hypermobility. I mean, those go together, right? But some of my patients really just have POTS symptoms and they don't have a lot of MCAS, they don't have a lot of hypermobility. Like there's little tweaks of it, like you can get a glimpse of it, but it's not really there. Or they really, really have MCAS and there's not a lot of hypermobility and POTS, or they have a lot of hypermobility and they don't
Yeah.
have the other stuff. And there's plenty of people out there who are hypermobile who don't have true,
Yes.
debilitating symptoms from POTS and MCAS, but they do have hypermobility, and there are, things that go along with that, right? And so I think it is possible. It's a spectrum. All three of them are on a spectrum, and you can have a lot of one and not a lot of the others, and that could just be your genetic predisposition or the way you were born. It doesn't have to necessarily relate to factors that came in,
Hmm.
um, or it could. Who knows, right? But I do think that I see patients that have these like flavors that are all different.
Yes.
So
And so, quick question. In saying
yeah,
that, would a patient who doesn't have severe MCASI symptoms and debilitating POTS, would you still trial them on an antihistamine or a mast cell stabilizer prior to beta blockers?
yeah,
You would. Interesting. And do you find that would,
probably.
like a Zyrtec or something like that, just something simple?
Hmm.
And would that,
Yeah, or even just like quercetin, not
yes,
necessarily Zyrtec or Pepcid. If they really don't have a lot of mast cell symptoms, I sort of start with the mast cell stabilizers.
yeah.
So I would start with vitamin C,
Oh,
quercetin,
amazing.
vitamin D, that kind of picture,
Yeah.
not necessarily the antihistamines
Okay.
themselves.
That's, yeah, I love that. I love that. I love that. I'm hearing this from a cardiologist. It makes my heart sing. Um,
I'm like not your average cardiologist.
no, of course not. Um, yes, it will be recorded. This will be on YouTube. Do you foresee patients having to take these meds for life?
No,
Okay.
I don't. I have a lot of patients. What I foresee is when I see patients, I try to get them on medications that can get them to a point of functioning,
Hmm.
then to a point of minimal exercise, then more exercise. Once someone is exercising every day and more active, their pot symptoms get better. They start like, you know, chilling out. And oftentimes I can peel back on medications. Same with the MCAS. I mean, once you're in a stable place, you can start peeling back.
Yes.
A lot of times, if I fix their pelvic venous disease, their POTS meds come, start trickling off. And so it's all about getting them to a stabilization and then to a point where it's not just stable, but you're actually functioning normally and you can do activities that you used to be able to do. That's when I start peeling back. And I don't, some people are on meds lifelong, yes, but I don't think it's 100% everyone. And I don't think when I start these medications, I'm not thinking you're going to be on this for the rest of your life. I'm hoping to get you off of
I'd love to come off my beta blocker, but I also have prolonged
them.
QT syndrome, and every single
Yeah,
cardiologist is
well, that's a
not a
unique,
negotiable.
it's not negotiable. You could probably get on a low dose, but
Yes, I'm on a low dose, but I just want to say I had a really good result from my ovarian vein embolization because they didn't find that I had, compression higher up that was causing dilation of the gonadal vein.
right.
It was primary, maybe from pregnancy. I don't know. Um, but
So I'll say that Steve Smith is the person who's, I mean, one of the people, but he really started like thinking about POTS and these other things, migraine especially.
oh
Like he
yes.
was doing ovarian vein embolizations, and then people's migraines were getting better, or their chronic fatigue went away, or their dizziness went away, and he was
Oh
like,
yeah.
"What? That's
Yeah.
why is all that
I've seen.
happening?" And he started
Yeah.
thinking about it. Yeah.
Yeah.
And so then, that sort of evolved into the iliac vein compression and what's going on there. And, other people started getting involved with the iliac vein and looking at that. Brooke Spencer is huge in this space, and she's like an incredible interventional radiologist. She was sort of on the same page as Steve Smith in the very beginning. And so, but yeah, people were getting better just from the ovarian vein embolization for sure. But if you have other stuff, it probably needs to be fixed too.
Yes. I mean, it's helped stabilize my blood pressure. Apparently, there was a lot of blood pooling. Um,
Right.
yeah, a lot of blood pooling. So higher blood pressure is has been a good thing, but it hasn't helped too much with POTS symptoms like the postural tachycardia or the dizziness. But interestingly,
Hmm.
then, it's not just the low blood pressure that's causing those symptoms. It just illuminates that.
Yeah.
Yeah.
Well,
Um,
having a little bit more blood pressure helps in general. So
yes.
that's like one step. Yeah.
Yes. Um, we will have to go soon. Do you want to just pick one or two more you want to answer? We do have quite a lot
Um,
there, but
oh my gosh. Well, so here's one concussion,
oh,
and now being treated for POTS. This is something I see all the time, but
mhm.
concussion is often a trigger for POTS and
Yes.
sort of that cascade of POTS, mast cell activation syndrome, all of the things. So
Yeah.
that's not uncommon. Um, there's so many other things
Yeah. Yeah.
we could talk about. We should
What
do this
about
again.
what about this as a last one? I think this would be great for you to answer. Beta blockers, ivabradine, midodrine, droxidopa. Do you see that one?
Yes, I found. Oh wait, let's see. I found beta blockers impacted my MCAS too much to tolerate. Ivabradine plus midodrine don't really do the trick. Didn't tolerate droxidopa. If my MCAS is better treated, would beta blockers potentially be better tolerated? Not necessarily. I think I would try a calcium channel blocker personally. There's also many beta blockers, so
Mhm.
trying one or two isn't necessarily enough. You might need to try five before you find the one that works for you. The other thing you need to remember is that patients with MCAS have intolerance to medications because they react to the excipients
The
in the pill,
color.
so the
Yeah.
inactive ingredients in the medication. So it's possible that all the drugs that were tried had the same, you know, hydroxycellulose or polysorbate or whatever it is that's filling the pill. And if you try a beta blocker that doesn't have those ingredients, or you get a beta blocker compounded, that you might have a better result from the medication. So, those are things to think about too.
Yes. And I found that even the same drug that was manufactured differently, one with color, one without color, I would respond differently to. So be mindful of that. You
Yeah.
may need to get something compounded.
Yeah. True.
So I'm so sorry, but we are going to have to run. This has been wonderful. It's been so good having this conversation with you, Alexis. I love that we were able to pick your brain and to hear your
I
perspective
was,
from all this, your
yeah,
expertise.
happy to be here for sure.
Your expertise is so, so valued in our community. We need more people like you. Thank you for advocating for patients like us. It does mean the
Sure.
world. So, this will be recorded. And Dr. Cutchins, can you tell us where people can find you on socials if they want to find you on Instagram or any
Um,
other
yeah,
platform?
Yeah, so I'm on Instagram at Dr. Cutchins. I have a website, cutchinscvm.com. That's the website of my clinic. I'm no longer at Emory in Atlanta. I've opened a private practice in New York City. I am seeing patients there, hopefully, fingers crossed, in November.
One,
But I've started seeing patients over telehealth in certain states where I'm licensed. So that's Georgia, Tennessee, Colorado, Pennsylvania, Ohio, Wisconsin, New York,
mhm.
um, Colorado. Did I say Colorado?
You did.
So if you're in any of those states, I can see you over telehealth. Uh,
Mhm.
or, if you happen to be in the tri-state New York City area and would love to see people in person, that's my dream, is to just,
Yeah.
do it in person. But
Yes.
so yeah.
Wonderful. And if you're watching this on YouTube, links to our socials and websites will be below the video. So thank you so much for joining us, everybody. Wishing you all a very beautiful day or evening wherever you are. And yes, happy Dysautonomia Awareness Month. Let's continue to raise awareness for dysautonomia.
Yeah, thank you.
Thank you. Take care. Bye bye.